Can we start?
I think we can.
Okay. Dr. Prashant?
Yes, good evening,
Can
everyone.
we start? Yes.
We should start on time. Thank you so much, Dr. Deva, for taking the lead, and Dr. Vasudha for taking up the session today. Over to you, Deva, to introduce us.
इंटरव्यू ने सर्टिफिकेट दी ना भाई जी यार
खबर में पाई ऐसा
Before we start, could I request all the participants to mute themselves, please? Thank you. So good evening, everyone. Welcome to this month's SNCC evidence review. Today we have an exciting topic, DVT prophylaxis in neuro ICU, by a very well-known speaker. I mean, Dr. Vasudha does not need any introduction. She is a well-known neuro anesthetist and intensivist. She was the secretary of the SNCC before, and now she is the director and head of neuroanesthesiology and neurocritical care at Max Super Specialty Hospital in New Delhi. And she's going to talk us through DVT prophylaxis in the neuro ICU. She's going to review the evidence and tell us how and when we should administer DVT prophylaxis. Over to you, Dr.
So much, Deva.
Freedom Accelerator.
And
we're going to go
can
a little
everybody
more
mute
detail
themselves?
We already started with. We're going to move it a little more.
Could I request everyone to mute themselves, please?
All right, thank you.
Thank you.
Thank you so much. And what I'm going to talk today is a real world problem, DVT prophylaxis in the neuro ICU. And we're going to talk about evidence-based approach to VTE prevention. The thing is, why is this topic being talked about? Thromboembolic prophylaxis is actually a very crucial aspect of patient care. We very often admit patients to the neuro ICU, whether it's someone recovering from a massive stroke who's just undergone a mechanical thrombectomy, or a trauma patient coming with a severe head injury, or someone post-craniotomy. We immediately focus on protecting their brain. But while we are vigilant about controlling the ICP, maintaining cerebral perfusion, preventing secondary brain injury, we are silently ignoring something that is a killer condition, preventable, which is happening down in their lower limbs, and that is deep vein thrombosis. And the reality is stark. 18 to 50% of neurosurgical patients actually develop DVT. And in the most acute ischemic stroke patients, post-thrombectomy, a very common subset of patients that comes to us, the incidence climbs to as much as 27%, sometimes even higher. That DVT prophylaxis in neuro ICU remains paradoxically neglected. Why we are
I request everyone to mute themselves, please.
So we are afraid, we are caught between two competing fears, the fear of allowing thromboembolic complications versus the fear of intracranial bleeding from anticoagulation. But, here's what the evidence tells us. It is not a binary choice. With evidence-based protocols, we can effectively prevent thromboembolism without significantly increasing hemorrhagic complications. So it is not about choosing between protecting the brain or protecting the body. It is about doing both simultaneously, safely. So today, in the next 30 to 40 minutes, I'm going to walk you through the evidence, the myths that hold us back, the pragmatic approach that should guide our DVT prophylaxis strategies in every neuro ICU patient that we are caring for. Now, to begin with, Yes. Why DVT prophylaxis in neuro ICU? Now, I told you the risk is real. And, as compared to the general ICU, where the risk of DVT is around 2% only, in the neuro ICU, the estimates range from 14 to 30% without prophylaxis. And even with prophylaxis, it is 2.5 to 21%. Why is this risk so high? We usually have patients with poor GCS, moribund patients, usually immobile, hemiparesis, paraplegic, lots of coagulopathic conditions happening. So there's a definite increased risk. And if it converts into a pulmonary embolism, it is associated with a 20 to 40% mortality in neurocritical care patients. Not to forget the significant morbidity, prolonged ICU stays. So prevention and effective management is of paramount importance in clinical practice. This is what I want to emphasize before I begin talking about everything else. The highest risk of VTE in severe TBI, large ischemic strokes, ICH, SAH, spinal cord injury, we know that. And still, we are so skeptical in starting with DVT prophylaxis. The practices vary. We're going to talk about how practices vary in the best of hospitals across the world, where the compliance to DVT prophylaxis is less than 20%, as against the targeted plus 90% from the guidelines. Now, talking about pathophysiology, the Virchow's triad, the factors that predispose to thrombosis, which is a foundation of the pathophysiology of thromboembolism, this gets augmented in cases of neurosurgical patients or neuro ICU patients. Why? Because there is an increased risk of venous stasis. Patients are paralyzed, immobilized, moribund, poor GCS. So there is a decreased venous flow. There is trauma. There is inflammation. So there's a lot of endothelial injury. Plus, our patients usually have a lot of catheters in situ. So they have urinary catheters, central lines, and all sorts of catheters, plus the hypercoagulable states that we see in TBI, SAH, strokes, and all of that. So, our patients are at a particularly increased risk. Now, the problem is the prophylaxis dilemma, which is a major challenge. I talked about the risk factors, which predispose to a high risk of venous thromboembolism, but at the same time, we are skeptical because of the risk of bleeding complications due to pharmacological prophylaxis. And therefore, we need to stress on a careful risk-benefit assessment. And therefore, when I talk about starting DVT prophylaxis, I need to emphasize the role of a protocol. Our decisions should be protocolized. And in that particular protocol, we should have risk assessment coming in as the first point of any protocol for DVT prophylaxis. If we know that our patient is at a higher risk, we would always go in to start on with the prophylaxis in a hasty fashion or faster. So now there are various risk assessment scales that have come up in ICUs, which are used across the globe. There are general risk assessment scores like Wells criteria. So, till very recently, I was using the Wells criteria only in my neuro ICU, although that is for general ward patients, not even specific to the ICU. Forget about the neuro ICU. So there are a lot of scores that are prevalent. I'm going to talk about a few scores that have found validity in neuro ICUs, and they include the Caprini score, the RAPT, and the test scores. And then there is something specific to ICU, and that is the ICU VTE score. Followed by that, there is a risk assessment prediction model that has come up very recently in 2025. And I'm going to speak about it. But please remember, the first step in any protocol for DVT prophylaxis is the risk assessment. Now, this is the Caprini score. Now, the original Caprini score was for surgical patients, and its application in medical ICUs like neuro ICU can be a little tricky, with many patients falling into high risk categories, potentially overestimating risk or underestimating benefits of prophylaxis compared to specialized ICU scores. But you see, Caprini score is the most validated out of all because it has certain neurospecific factors. Now, Caprini score actually, it is a very lengthy score consisting of 38 points actually, but there are certain factors in those points which are neurospecific, like CNS malignancy, major neurosurgery, paralysis, GCS less than 8, along with other patient factors, immobility, and vascular factors. Now, vascular, again, very predominantly seen in ICUs, neuro ICUs, presence of central venous catheters, mechanical ventilation. So most of our patients are ventilated. They have all these ICU catheters in place. There is sepsis, elevated D-dimers, thrombophilia. All of these conditions might be seen in our ICUs as well. And this is the rate as per the Caprini score. More than 8, the risk of VTE is around 11 to 12%. So it is recommended that use Caprini as a primary screening on admission for all neuro ICU patients because of its robust validation. Now, coming on to the rest of the scores, the RAPT score is risk assessment profile in trauma, in thromboembolism score, which is usually used in neurotrauma. Again, there are 19 items in the RAPT score as compared to the 38 items that were there in Caprini. Now, the advantages over Caprini is it has a higher specificity in TBI, actually. This was originally designed for trauma. So in TBI, the RAP score may be better for assessment of risk, DVT risk in patients. So there are certain critical TBI items in this as well. So we have, let me just point out the laser here. So we have abbreviated injury score of more than 2 for the head. We have a GCS of less than 8 here. We have pelvic fracture, spinal cord injury. All these are neurospecific factors, and therefore we found applicability of RAPT score in neurotrauma as well. It can be a perfect complement to our Caprini chart for neurotrauma cases. There is another scoring system called the trauma embolic scoring system. This actually gained validity in military trauma. All right, so it is a very simple score, readily available clinical data is used, making it easy to calculate. So there is age, injury severity, pre-existing obesity, ventilation days, and lower extremity fracture. And a score of more than 7 serves as a high risk cutoff, demonstrating pretty good sensitivity, over 90% in some studies. And specially validated in military trauma patients. Now, there is this recent comparative analysis of all these 3 risk assessment scales for predicting thromboembolism in TBI patients, and they found that RAPT score was the best as compared to Caprini or TESS. Better predictive effectiveness for VTE risk in TBI patients. So particularly TBI we are talking. Now, another risk score is ICU VTE prediction model. So this is a validated tool specifically for assessing risk in ICU patients. There are 8 independent risk factors: history of previous thromboembolism, multiple trauma, age more than 70 years, platelet count, which may be high platelet count, immobility, invasive mechanical ventilation, CVC, or respiratory failure and heart failure. Now, if you see the trend, most of these factors are actually common amongst across all these prediction models. So actually, it is the presence of immobility or prolonged ICU stays or increased D-dimer levels or thrombophilias and all those factors which are actually contributing to an increased DVT risk. Now, when we compare all of these scores, we see that Caprini might be the best overall for neuro ICU because it has a broad validation, validated across TBI, stroke, craniotomies, and scores more than 12 indicate higher risk, but it is a lengthy one. The American College of Chest Physicians recommends using the Caprini score to assess the risk of VT in hospitalized patients. For neurotrauma, as I told you, RAPT and TESS are recommended. So they say use RAPT first for TBI and then TESS as confirmatory for polytrauma. And Caprini you can use for stroke and non-trauma patients. Padua improved these we do not use in the neuro ICUs much. I have to mention about this particular study that has come up in 2025, talking about risk assessment of VTE in neurocritical care patients, particularly. This is for the validation of a clinical prediction model. So while ICU VTE scoring, Caprini scores, they provide a baseline neuro ICU management. They provide a baseline, but then there are certain neurospecific factors like GCS ventilation, balancing VT prevention, bleeding risk, and all of that, that needs, particular mention in neuro ICU. So these are the 8 variables that I use in this particular clinical prediction model for neuro ICUs: age, length of ICU stay, APTT, D-dimer, length of tracheostomy, pulmonary infection, antibiotic use, and dehydrating agent use. You would see there are 2 neurospecific predictors, and that is the use of dehydrating agents like mannitol and the length of tracheostomy. So tracheostomy duration. Amongst all of these factors, the D-dimer levels and length of ICU stay duration, they contribute most significantly to the total score, actually. Now, this is a very easy to implement score. It is an immediate bedside implementation score. You can do it within 2 minutes at the bedside of the patient. I have to tell you, this is a nomogram-based prediction model. Now, those of you who do not have an idea of what a nomogram is, can you see all of these? These are the points and these are the various factors that determine. Now, what you do is you simply draw lines, parallel lines, depending upon where you place your patient. So if the age is 40 years, you draw a line here like this. Similarly, if your length of ICU stay has been 20 days, you draw a line like this. And then you summate and you get a score. And this is a very quick way with excellent calibration, a practical nomogram, neurospecific. So it has a very good clinical utility. Yet to find a widespread use with clinical validation studies further, but I needed to mention this one because it was specific to the neuro ICU. Now, remember, rather than relying on a single cutoff score, you should always have a comprehensive approach. So to determine the appropriate DVT prevention strategy, you consider the overall clinical picture, the specific risk factors that are present, and the patient's individual risk of intracranial bleeding. So this was the first part of the protocol that I was talking of. We have spoken about the various risk assessments that can be done prior to starting a DVT prophylaxis. Now, the next step is identifying the gaps in neurocritical care. What are the problems which, prevent us from using DVT prophylaxis as commonly as we should? So what is the problem? There is an underutilization of timely prophylaxis. So 53% practice it less often. So only 40 to 60% compliance is there for because of bleeding concerns. So whereas the guidelines target that there should be a 90% compliance for the usage of DVT prophylaxis, there is an extreme underutilization of DVT prophylaxis in the neurocritical care. The timing protocols are heterogeneous because we always say that we need a stable CT before we start on with the pharmacological prophylaxis. So what is a stable CT? It may range from 24 hours to 7 days in ICH. It may be, 24 hours to 72 hours debate in TBI. In aneurysmal SAH, some start on day 1, some start on day 2, some on day 7. So there's a lot of heterogeneity in the timing protocols. And this is a key practice gap in neurocritical care. Now, again, there is a very less usage of risk stratification that I was talking about in the previous slides. Instinct is to treat everybody alike, treat all same. So there is a 60% overtreatment in patients who are low risk and 40% undertreatment in patients who are high risk. So it is always recommended that you use assessment scores like Caprini or RAPT. They are underused, less than 30% routinely. You can use the nomogram integration because it has a superior calibration. There is a confusion about whether to use low molecular weight heparins versus unfractionated heparin for pharmacological prophylaxis. Now, again, there is a robust evidence in favor of low molecular weight heparins, and I'm going to talk about the PREVAIL study in my subsequent slides. But 45% of clinicians still prefer unfractionated heparin. The reason being that it is quickly reversible in case there is a bleeding complication if it happens. There are dose inconsistencies. So whether to give Clexane 12 hourly or 24 hourly. So there's a lot of confusion over the dosing or the type of agent that should be used. Then there are prolonged interruptions. Now, frequently we hold the pharmacological prophylaxis if the platelet counts fall, if there is thrombocytopenia happening, or the creatinine levels rise and the patient is going towards renal failure. We tend to interrupt and stop the Clexane or whatever low molecular weight heparin is going on. But then there is no protocol for when safe to restart. So there are restarting delays. Average is 72 hours post-resolution. Now, next is inadequate duration. Now, despite knowing that conditions like spinal cord injury is a very high risk case for DVT, and there is a 65% DVT risk in the first 3 months, still the prophylaxis is usually given for like 14 days or 21 days. Whereas the guidelines recommend giving it for around 8 to 12 weeks. So there is an inadequate duration of DVT prophylaxis that is given. And then there is something called mechanical prophylaxis failure. Now, as a protocol, we assess the risk of the patient. We begin with mechanical prophylaxis in the form of IPCs soon after admission. And then after the CT is stable, we go in to start with pharmacological prophylaxis. This is the usual protocol that we follow. But now the problem is there are certain situations where mechanical prophylaxis has failed. Now, failed in the sense that, because of non-compliance, the patient is not comfortable and he refused to have the IPC in place, or because of the positioning, or the cuff was not tight enough, or there's a skin breakdown happening. So mechanical prophylaxis was discontinued. So non-compliant IPC, start pharmacological prophylaxis. But these kind of protocols are entirely lacking in our practice. So these are the key practice gaps in neurocritical care, which we actually need to address if we want to have a good compliance to DVT prophylaxis across all our neurocritical care units. Now, this was a very good cross-sectional survey published by Dr. Sharmili and colleagues in the Indian Journal of Anesthesia, and she found that thromboprophylaxis practice patterns are quite diverse in neurocritical care patients, and they are practiced less often in neurocritical care than in general critical care, and there is a reluctance to use heparin because of the fear of bleed. But they concluded that there was a preference to use pharmacoprophylaxis in patients with GCS less than 9, and low molecular weight heparin was the preferred choice. Now, there is a scope for improving the impact potential, so always going for a protocolized approach. There is a 20 to 30% reduction in the incidence of VTE if we follow a protocolized approach. There should be a risk stratified timing, so always assess the risk that would decrease your overtreatment by 40%. The staff needs to be trained adequately. Especially, I was talking about mechanical prophylaxis failures. There, the staff training is very, very important. Compliance increases from 55 to 89%. Educate them that if they are not able to, use IPCs in their patient, they should report to the clinician, and we should go in for a chemical prophylaxis if it is feasible. So, staff training is very, very important.
This is 15.
The biggest gap is fear of bleeding is more than evidence. Can you please mute yourself? Okay, thank you. And protocolization closes 80% of gaps, and that is a huge thing. We need to have good protocols in place. Now, the talk was evidence-based, how and when. So the first part of the talk that I need to address is how should we give DVT prophylaxis, and with how I mean what are the ways in which prophylaxis is given. So there are 2 ways. Mechanical prophylaxis, kindly mute yourself.
You can go to Dubai. You want to go to Dubai? Jaldi.
Going to Dubai. Who is that?
iPhone, Mr. iPhone, please mute yourself. Thank you.
I muted, yeah. So, mechanical prophylaxis, we have graduated compression stockings, we have intermittent pneumatic compression devices. Graduated compression stockings, not very much used in neurocritical care, skin breakdown, and all of those problems are there. What is commonly used is the intermittent pneumatic compression devices. All of you would be aware of this picture in your ICUs. These are these are IPCs, intermittent pneumatic compression devices. Actually, we now use SCDs, sequential compression devices. Now, what are ICDs? They are the IPCs. These are nothing but, alternate inflation and deflation of the device, leading to increasing the venous return from the calf muscles. Now, these may be indicated immediately on admission, and especially when anticoagulation is contraindicated, like in patients of bleed. So what we can do as an immediate measure for DVT prophylaxis in all our patients, irrespective of the etiology, is to put IPCs in all of them. Now, I was talking about sequential compression devices. They have split pockets of inflation on the sleeves, actually. It helps to squeeze in a milking action. So the pockets inflate sequentially, starting from the most distal pockets, followed by subsequent topics in the same manner. And this promotes distal to proximal venous drainage. Now, usually, how does this machine operate? There are 12 seconds for inflation for venous emptying, alternating with 48 seconds for deflation to allow venous filling. Now, the pressure that it gives is usually 30 to 60 millimeters of mercury. Now, the problem, okay, so we have to initiate within 24 hours, and there is a 40 to 60% effective DVT reduction. There is no bleeding risks, absolutely safe in hemorrhagic stroke. The primary problem is compliance issues. I was just talking about them. The nurse discontinues the IPC when she's taking the patient out of bed, or there is incorrect application because they're leading to improper cuff fitting. There may be skin breakdown. So all these may be compliance issues. So whenever there is some issue, you should always do a quick check if the device is positioned correctly, if the machine is functioning as designed, if the patient is comfortable and compliant with use, regular skin checks to prevent skin breakdown or pressure injuries. So these are the things, practical things that you should take care when you are applying IPCs, and more so because at times we are solely relying on mechanical prophylaxis in our patients when there is a high bleeding risk and we are not able to use pharmacological prophylaxis. So we should avoid as much as possible all these compliance issues that come up. Yes, there are certain contraindications to the use of IPCs, presence of DVT, extremity wounds, severe edema. There you can use your intermittent pneumatic compression devices. Now, effectiveness of IPCs, multiple studies across all etiologies. This was one of the largest studies, CLOTS 3. This was published way back in 2015, and it was a multicentric randomized trial. Around 3,000 patients with stroke were enrolled. All kinds of strokes, ischemic as well as hemorrhagic, and they found an absolute risk reduction of thromboembolism of 3.6%, and possibly improved survival in a wide variety of patients who were immobile after stroke. So this was a huge study demonstrating the effectiveness of IPC in stroke patients. This was a study that came up in 2024, actually, in patients undergoing elective craniotomy. So effectiveness of IPC. So intraoperative IPC reduced the risk of DVT by 64.6%, actually. So this actually, I have quoted the study in order to, press on the point that it is equally important to use DVT prophylaxis perioperatively, because our surgeries, the neurosurgeries, are usually prolonged procedures, and the risk of DVT during the surgery as well is real. So use IPCs in patients undergoing elective craniotomy. Now, this was published in 2005 in patients of acute intracerebral hemorrhage. So prevention of DVT with the use of IPCs in ICH, and this was in severe TBI, effect of IPC. So IPC has a robust database to support its use. Now, after mechanical prophylaxis, once the patient has stabilized, the CT has been stabilized, and we're going to talk about when do we say that the CT is stable a little later. But then after this, we start on with pharmacological prophylaxis. And this is a tricky thing to do. Why? Because this is the intervention that actually leads to bleeding complications. So we have to be very careful, and we have to weigh risks against benefits. Now, what are the agents available for pharmacological prophylaxis? We have two types of heparin. So we have unfractionated heparin, and we have low molecular weight heparins like enoxaparin, Clexane that we call, or we have dalteparin fragments that we call. And then we have fondaparinux. Erixtra. Erixtra is used for heparin-induced, wherever there is a heparin-induced thrombocytopenia. Now, we're going to compare all of these drugs, which one is superior over what. So a lot of evidence for enoxaparin, especially in stroke, the PREVAIL study, where it has been proven to be superior to unfractionated heparin. We start it after we have a stable CT. And how do we monitor the effect of enoxaparin? That is with the help of anti-10A levels. In the West, anti-10A levels are measured after giving the second dose, 4 hours after giving the second dose. In India and resource-limited nations, we do not have anti-10A monitoring systems in place. Another LMW heparin is dalteparin, which we call Fragmin in general use. So 5,000 units subcutaneous, we give OD. This is particularly favored in patients who have a poor creatinine clearance, in patients of, compromised renal functions. Then we have, of course, our unfractionated heparin, the usual heparin that we use. It is readily reversible with the use of protamine, and the dose is 5,000 units, 8 hourly. So we need to give it after every 8 hours. And fondaparinux, 2.5 milligrams OD is the dose, particularly helpful in cases where HIT has been reported. So we cannot use any kind of heparins, though the incidence of HIT is very low with enoxaparin, but then HIT does happen with enoxaparin as well. So if there is a documented heparin-induced thrombocytopenia, we should prefer using fondaparinux instead of any kind of heparin. Now, this is a comparison of unfractionated heparin and enoxaparin for your quick reference. If you see that enoxaparin has a very high bioavailability, 100% bioavailability as compared to unfractionated heparin, small molecule with a low molecular weight, and predominantly anti-10A activity. So this is a proportion with both anti-10A and anti-2A activity. So while unfractionated heparin has both anti-10A as well as anti-2A, enoxaparin has predominantly anti-10A activity, and therefore it is partially reversible with protamine. Maximum neutralization of approximately 60% of the anti-factor 10A effect. Now, next thing that we need to stress on is excretion. So while enoxaparin is mainly cleared by urine, so it is dependent upon the renal clearance, unfractionated heparin is primarily metabolized in liver and spleen, and therefore we switch over to unfractionated heparin if the creatinine clearance falls below 30%. Now, next thing is regarding the half-life elimination, 1 to 2 hours for unfractionated heparin, and therefore we have to dose it more frequently. The dosing is usually TDS, 5,000 units subcutaneous, as against enoxaparin, which has a longer half-life. So the dosage is usually BD or OD. So we know that it has a predictable effect. Enoxaparin is more predictable as compared to unfractionated heparin. The risk of HIT, if we see, is 2.6% in unfractionated heparin as against 0.2% with enoxaparin. Now, before I move ahead, some practical points. Administration technique, all these injections are subcutaneous. So there should be a protocol in place. You have to inject its subcutaneous in the abdomen, 2 inches from umbilicus, rotate sites always, injection at 45-degree angle, 25 to 27 gauge needle is used, no aspiration, no massage post-injection. Confirm there is no active bleed before administering the dose, and perform neurochecks hourly for 4 hours at least post-dosing. There is a therapeutic drug monitoring available. I just talked about it, but it is not available in our country. I mean, it may be available, but not widely used. The target is 0.2 to 0.4 international units per ml. And it is done 4 hours after the second dose is administered. Daily orders, you should monitor platelets to exclude HIT. So ideally, every 48 hours, platelets are monitored for 7 days. We should perform frequent leg examinations for swelling, tenderness, or hormones. So Homans is an outdated thing now, not very reliable. It was ankle dorsiflexion to elicit pain in the calf muscles that actually indicated towards DVT. Neurochecks should be done every 4 hourly for bleeding surveillance, and abdomen should be examined for injection site hematoma. And the nurse should also be clear about the hold criteria. If the platelets fall below 50,000 or there is or there is more than 50% drop, you have to hold the heparin in use. Systolic BP more than 180 kind of precludes because of the fear of bleeding progression. Drain output more than 100 ml per hour in post-craniotomy patients, and creatinine clearance falling less than 30%, we have to switch to unfractionated heparin. Now, this was the Prevail trial that I was talking of. A huge trial, actually, around 1,800 patients it took for acute ischemic stroke, and they were administered enoxaparin 40 milligrams subcutaneous OD or unfractionated heparin 5,000 units every 12 hours for 10 days. And what they observed was that enoxaparin reduced the risk of thromboembolism by 43% as compared to unfractionated heparin, and that is a huge percentage difference. So it was 10% risk of DVT with enoxaparin versus 18% with unfractionated heparin. So this was actually published on the main page of the Lancet. The cover page said, for patients with acute ischemic stroke, enoxaparin is preferable to unfractionated heparin for venous thromboembolism prophylaxis. This was way back in 2013, actually. But then it reiterated better clinical benefits to risk ratio, and there is convenience of once daily administration for enoxaparin as well. So yes, enoxaparin preferred over unfractionated heparin, and the evidence is quite robust for stroke patients. This was about how. So we have discussed about the ways in which prophylaxis may be given. Now, the bigger question is when. So there are certain general principles. Start as early as safely possible. And for this, you need an imaging stability. Your CT scan should be stable. There should be no hemorrhagic conversion. There should be no increasing mass effect or midline shift, no ongoing bleed. Your coagulation profile should be acceptable. Only then you can go ahead and start with on pharmacological prophylaxis. And please remember, mechanical prophylaxis does not replace pharmacological prophylaxis. So mechanical prophylaxis alone offers just a 40% safety for DVT. Pharmacological prophylaxis needs to be started after an acceptable time limit whenever it is feasible. So always think about starting on pharmacological prophylaxis as and when feasible. We're going to discuss disease-specific conditions, and I think most of us are actually looking forward to the guidelines for each condition individually. Ischemic stroke. So as soon as the patient gets admitted, mechanical prophylaxis immediately on day 0. And chemoprophylaxis, that is heparins, depends on the reperfusion strategy that has been offered, IVT or intravenous thrombolysis or endovascular thrombectomy or both. Post-treatment imaging if the CT is stable, and presence of hemorrhagic transformation. I'll discuss the reperfusion strategies individually. Please remember, no antithrombotics in the first 24 hours after IVT. Very, very important. Now, delays beyond 48 hours, they increase the VTE risk without proven safety benefits. So please do not unnecessarily delay your pharmacological prophylaxis beyond 48 hours. Decide if there is no contraindication to the starting of to the initiation of pharmacological prophylaxis, please go ahead. Now, depending upon reperfusion therapies I was talking, so post-intravenous thrombolysis, start pharmacological prophylaxis 24 hours later if the imaging is stable. If you see small asymptomatic petechial hemorrhages, it is usually safe to start, but if there is a parenchymal hematoma, delay. You cannot start immediately. You have to reassess. Now, post-endovascular thrombectomy, it is said you can begin actually immediately, but we say start 12 to 24 hours later if CT confirms no hemorrhage. So we do not start immediately after the procedure. We perform a CT 12 to 24 hours later, and then we can go ahead if the imaging is stable. But you have to consider delaying if the infarct core is large. There have been multiple passes during the procedure, and there is significant contrast staining. You would have observed in post-thrombectomy patients, you have lot of hyperintensity that the interventionist contributes to a contrast extravasation rather than a frank hemorrhage. So if there is significant contrast staining versus hemorrhage uncertainty, then we should hold. We should not go ahead with starting off pharmacological prophylaxis. When there is a hemicraniectomy performed for MC infarct or for any acute ischemic infarct, malignant infarct, we can start start the prophylaxis usually after 24 to 48 hours after the post-op CT is stable. Now here in stroke, we also need to know when to delay beyond standard timing. This is all about when to start it. When do you need to delay beyond the standard timing? If there has been a large infarct core, there is a very high risk of hemorrhagic transformation. But then again, there is a point which says that imaging stability is more important than infarct size thresholds for starting chemoprophylaxis. These are the AHA, ASA guidelines. So if your large infarct core has been stable for 48 hours, you can think of starting pharmacological prophylaxis carefully. You have to be extra vigilant here. Now, you have to delay starting pharmacological prophylaxis if it is malignant MCA, if you are planning a decompressive craniectomy in that malignant MCA, or if there is neurological worsening. In all these conditions, please do not be, very, very prompt in starting DVT prophylaxis in the form of, these drugs, because bleeding complications may happen. Now, coming on to another very, very important disease condition, and that is intracranial hemorrhage. Practically, clinicians abstain from giving DVT prophylaxis, pharmacological prophylaxis in ICH. But please remember, risk of DVT in ICH is 4 times higher than in patients with acute ischemic stroke. So the incidence is real. We have to, be very careful about DVT prophylaxis in ICH. Now, there was a recent meta-analysis of 9 studies, more than 4,000 patients, and they reiterated that prophylaxis with any type of heparin is not associated with a significant increase of hematoma expansion or extracranial hemorrhage. So please don't be wary of starting your heparins for the fear of hematoma expansion after your CTs have stabilized, is what they wanted to emphasize. Now, it may be reasonable to first document hemorrhage stability on CT if prophylaxis is started in the 24 to 48 hours window after onset, and timing of initiation in presence of an EVD and after surgical decompression. We have limited data for that, and there is high practice variability, institutional preference, surgeon's preference is taken into account. So I was talking about compliance rate goes up to 7 days after, ICH onset. So these are the gray areas, the knowledge gaps that we have where we really don't know the correct answers. We have to weigh risks and benefits and be more proactive in starting DVT prophylaxis than in holding back. Now, very recently in 2022, a risk score has come up, ICH DVT score, a novel risk score to predict deep vein thrombosis after ICH. So risk assessment can be performed using all of these parameters: age, hematoma volume, subarachnoid extension, presence of pneumonia or GI bleed, and length of stay. And score of 18 and beyond is considered high risk. Now, this particular paper also gave us a model of RPR, risk prevention reassessment model, to prevent in-hospital DVT after ICH. A very interesting paper if you go through. They say step 1 is to assess the risk, stratify potential risk. Step 2 is prevention. So apply tailored preventive strategies based on potential risk. So tailored. Don't be too aggressive. You have to look for CT stabilization. Step 3 is reassessment. Keep on reassessing the status of thromboembolism periodically, or when the patient's condition changes, like if the stroke recurs or there is occurrence of pneumonia, all these things are going to increase the risk of DVT. So you have to keep reassessing. The RPR model should be followed in patients who are presenting with ICH. And when we look for compliance, is prophylactic anticoagulation for DVT common practice after ICH? Very interesting paper in Stroke 2015. And this was in one of the best ICUs in the US. And they said less than 20% of patients with ICH receive anticoagulation for DVT in the US. And when used, the time to initiation is less than 2 days and less than half of the patients. So later timing of initiation is also late, and the number of patients who are receiving anticoagulation is also only 1/5 of those many who should receive. So actually, we need to, introspect in ICH. These were the guidelines and reviews, the NCS guidelines, as well as a 2024 review regarding venous thromboembolism prophylaxis after spontaneous ICH. Why I have written down both of these is because in both these, they emphasize on early initiation of pharmacological prophylaxis, and that is 24 to 48 hours from ICH onset. So now the guidelines say you should initiate pharmacological prophylaxis within 24 to 48 hours. Initially, it was 24 to 72 hours, but now they say 24 to 48 hours. It seems to be safe, effective, and along with that, please remember early mobilization is a key point for DVT prophylaxis. So when we talk about mechanical prophylaxis in the form of IPCs, we should also reiterate the use of early mobilization in these patients. Now, mobilization does not necessarily mean moving the patient out of bed. We have moribund patients, poor GCS. So it may just mean passive exercises such as ankle movements, knee flexion extension exercises. Active exercises can be performed in bed. You can make the patient stand with the help of rehabilitation guys have a lot of techniques for mobilization. So early mobilization is the key, especially in patients who have a hemorrhage on CT, where you know that your pharmacological prophylaxis might get delayed because of one or the other reason. So as a rule, when to start? IPC should be started on day 0 for all ICH patients. And please remember, chemoprophylaxis is not contraindicated forever. Fear-based delays increase preventable thromboembolism. So the key decision point is 24 to 48 hours along with a stable CT. Stable CT, no increased hematoma expansion. Now I have come up with what defines a stable CT. No increase in hematoma volume. So if we see numerically and calculate the ICH volume, we see that the hematoma volume should not increase beyond 33% of what it was. No new hemorrhagic compartment, no worsening mass effect, no need for emergent neurosurgical intervention. If all of these things are present, we call the CT as stable. Now, we have talked about 2022 guidelines for ICH quite frequently in our discussions in neurocritical care. And from these guidelines, we have that start chemoprophylaxis if the bleeding is stable, coagulation is normal, and BP is compensated. So go ahead, start your chemoprophylaxis as early as 24 to 48 hours from ICH onset. Please remember. Now, coming on to subarachnoid hemorrhage, again, the risk is real. 4 to 24% will develop thromboembolism. Why? Because actually SAH is a hypercoagulable state, pro-inflammatory state, and all of these things, increase the risk for venous thromboembolism. Now, what should be done on admission? IPCs, yes. IPCs, early mobilization, everything should be followed. And for chemoprophylaxis, it is said you can start chemoprophylaxis within 24 hours after the aneurysm is secured. But if the aneurysm is unsecured, you need to individualize. Yes, of course, you have to take into consideration the bleeding risk of an unsecured aneurysm. Data on the choice of agent for pharmacological prophylaxis after SAH is not definitive. Actually, there have been studies on unfractionated heparins, and there is a paucity of data for the safety and efficacy of enoxaparin in SAH. So determining the most appropriate form of pharmacological prophylaxis, it will require an assessment of risk versus benefit for each patient. Maybe the reason may be that there are neuroprotective and anti-inflammatory properties in unfractionated heparin, and it is easily reversible. So maybe the tilt towards the use of unfractionated heparin in practice is there. Although the guidelines, 2023 guidelines that came up, they did not mention any agent. They just said pharmacological or mechanical thromboembolism prophylaxis is recommended to reduce the risk of VTE. NCS guidelines, they recommend unfractionated heparin over low molecular weight heparins. It is institutional protocol, usually depending upon the patient risk factor. So patients who are elderly, who have a poor creatinine clearance, there we have a tendency to start on with unfractionated heparin, but younger patients with good renal clearance, we usually start with low molecular weight heparins. None is contraindicated, however. Now, I have mentioned this particular paper because it was quite interesting. This was in 2024 in the Neurocritical Care Journal, pharmacological prophylaxis in subarachnoid hemorrhage requiring an EVD. Now, patients who have an EVD in place, pharmacoprophylaxis is less talked about. Now, this was actually a retrospective single center study, not a very robust body of evidence. But then here, what the authors did was they initiated chemical prophylaxis on the day of coiling and on postoperative day 2 if it was a surgical clipping. And the choice of agent was, again, as I discussed, they started on with low molecular weight heparins if the patient was young with a good renal clearance. And if advanced age and impaired renal function was there, they preferred starting on unfractionated heparin. And they concluded that the use of prophylactic enoxaparin or unfractionated heparin resulted in a similar incidence of VTE and secondary ICH. So none is superior over the other is what they concluded, and we can safely start prophylaxis even with an EVD in place is what their single center retrospective study told us. Obviously, there is a need for further studies to validate all of this. There are no good clinical trials here. Patients who have concurrent antiplatelet therapy, like patients who have undergone coiling and they also have antiplatelet therapy, there they could not conclude whether to start VTE prophylaxis or not, and they said that further studies are needed to determine the safety and efficacy of pharmacological prophylaxis in these patients. Now, coming on to traumatic brain injury, I am going to quickly wind up now. Traumatic brain injury, post-neurosurgical and SCI is left. So traumatic brain injury, yes, incidence is high as 50% for thromboembolism in TBI. What do the guidelines say? So this is a comparison of all the guidelines. The Brain Trauma Foundation gives no recommendation on when to start. The NCS guidelines and the ones that were given in collaboration, they said we should start chemical prophylaxis within 24 hours of TBI or within 24 hours after craniotomy. And if there is an ICH also present along with TBI, there are contusions, then we can begin within 24 to 48 hours. Now, there was a recent best practice statement given by the American College of Surgeons in 2024. And they said that you can start DVT prophylaxis within 24 hours if it is a low risk non-operative TBI and there is no TBI progression on follow-up CT. And 24 to 48 hours if it is moderate to severe risk. And in all of these guidelines, LMW heparin is preferred over unfractionated heparin, although you can use any of them depending upon your institutional preference. This was a recent one that was published in October 2024 in the Journal of Trauma and Acute Care Surgery. Actually, this was a comparative effectiveness study evaluating the impact of timing and agent on outcomes for patients with severe TBI. So, huge study actually. They enrolled around 13,000 patients. They collected data from 35 level 1 and level 2 trauma centers. And what they concluded was in patients with severe TBI, low molecular weight heparin use was associated with lower thromboembolism incidence without increasing mortality or neurosurgical interventions. And initiation should be less than equal to 48 hours. That decreases the thromboembolic incidence. So studies are coming up, clinical trials are coming up, which are reiterating our guidelines of starting early in less than 48 hours for TBI as well, severe TBI. Now, low molecular weight heparin is a preferred thromboembolic agent for severe TBI. Initiation less than 48 hours should be considered in relation to these risks and benefits. So, immediately start IPCs. Chemoprophylaxis 24 hours after stable CT, 48 to 72 hours in severe TBI, not 72 now. less than equal to 48 hours only, and LMW heparin preferred when safe. Coming on to post-neurosurgical patients, again, immediate post-op, actually perioperatively, we should give IPCs. Chemoprophylaxis can be started 24 hours post-op if no bleeding. In spine surgeries, early prophylaxis is critical, but you have to balance with epidural hematoma risk. So, neurosurgical patients, yes, the risk is high, long duration of surgeries, long immobilization time after surgery, possible neurological deficits which can negatively influence mobility. So you have to take care, especially the risk is high in patients who have undergone craniotomy for high-grade gliomas. There, the risk of thromboembolism is particularly high. We read one of the risk factors is presence of a malignancy. So start prophylactic strategy perioperatively because there is long immobilization and hypercoagulability. This was a systematic review for neurosurgical practice, and they included 25 studies. And what they emphasized here was that the DVT incidence might actually be higher than what you see, because at places the way they are screened is only clinical. So systematic screening for DVT is very, very necessary with the help of bilateral lower limb duplex studies, Doppler studies. So systematic screening for DVT reveals much higher incidence percentages in comparison to screening solely on clinical grounds. So that is recommended in follow-up of neurosurgical procedures with an increased risk for DVT development. Now, coming on last and very, very important, spinal cord injury. These are the various guidelines that have emphasized on the use of DVT prophylaxis as early as possible is what is documented, at least within 72 hours of injury, as soon as bleeding is controlled. So the latest one is WTA 2020, within 24 hours with moderate to high risk thromboembolism and stabilization of spinal cord injury. And which agent? Anyone, although LMW heparins are preferred. Overall incidence of DVT in spinal cord injury without prophylaxis is 62%, very, very high. And the greatest risk is after the first 72 hours post-injury and up to the first 2 weeks. Then there's a substantial drop at 8 weeks. So the current guideline-based recommendation is start DVT prophylaxis and continue for a minimum of 8 weeks following injury in patients with limited mobility. LMW heparins has been noted to have the highest level of evidence for use here. So IPC plus low molecular weight heparin as early as 24 hours, maximum by 72 hours. After 72 hours, the risk is going to increase. So by 72 hours, your pharmacological prophylaxis should ideally be in place. Early mobilization, passive exercise should be initiated ASAP once the patient is medically and surgically stable. Now, here I would like to mention that there is also a mention of the use of direct oral anticoagulants during the rehabilitation phase of recovery, and these were given in spinal cord injury guidelines of 2020. If your patient has undergone a surgery, you withhold LMW heparins on the morning of surgery only and restart 24 hours post-operatively. Continue for 8 to 12 weeks. Specific duration has to be individualized, but the risk is there up to 8 weeks. So continue longer than usual. IVC filter, they are not generally recommended. They are not safe when left in place for the long term. Unjustified cost again. But then you have to consider placing IVC filters if anticoagulation is not possible. IVC filters are actually used when there is a DVT, documented DVT present. So this is my concluding slide. I was talking about protocols, the practical neuro ICU algorithm. Once you admit the patient, IPC for all. So intermittent pneumatic compression devices should be applied to all. There should be a daily bleeding risk assessment. Repeat imaging at 24 hours if indicated. Start chemoprophylaxis early if there is a stable imaging. Hold if platelets is less than 50,000, active bleed or creatinine clearance is falling below 30. Resume criteria should be in place. So stable CT, platelets more than 50,000, you should resume the prophylaxis. Escalate to therapeutic anticoagulation only when safe. So what I need to emphasize is imaging stability. not fear should guide decisions. And chemoprophylaxis is safe when timed correctly. This is the golden rule that we follow. Again, the repetition: IPC day 0 plus LMW heparin on day 2 if stable CT results in 85% thromboembolism prevention with less than 2% bleeding risk. Thank you so much for your attention and your patient listening. Over to you, Dr. Deva. I have been speaking since the past 1 hour.
Thank you very much, madam, for that fantastic and really comprehensive evidence and guideline review on VT prophylaxis in neurocritical care. It is a practical problem that we face on a day-to-day basis in neurocritical care. Especially, we work with different surgeons who have who also have different thoughts, and they follow
Whims and
different
fancies, I
guidelines.
believe.
Yes,
Yes.
whims and fancies, of course. Yeah. I mean, your talk was, exceptionally clear, very well structured. I mean, it was easy to follow and, of course, clinically relevant. Thank you very much. And I can clearly say that I'm sure the SNCC members would appreciate the humongous effort that went in, behind this presentation. Lots of articles you've gone through and lots of guidelines you've summarized. Thank you very much, madam. Are there any questions? I don't see anything in the chat.
Sir, I have a question.
Yes, sir.
Sir, suppose patient is having a heparin-induced thrombocytopenia and patient recovered. So in that case, other than heparin, what are the agents which can be considered?
So as I told, if there is heparin-induced thrombocytopenia, we should prefer starting on with fondaparinux, Erixtra. So use Erixtra, even if your platelet levels have come back to normal, prefer to use fondaparinux instead of heparins.
What about bivalirudin, ma'am?
Sorry?
Bivalirudin.
I do not have many evidence in favor of that. Again, as I mentioned, in spinal cord injury, they even recommend using the newer oral anticoagulant drugs. But I'm not sure what is the effectiveness and what is the level of evidence to use them. I cannot comment on that. Maybe a personal preference.
Okay, ma'am. Thank you.
There's a question in the chat. How many times CT brain should be repeated to document it is stable?
Okay, so actually the usual practice is repeating CT scan within 24 hours. You do not repeat it very frequently. If your patient has deteriorated, yes, much earlier, or if your patient has undergone coiling or some interventional procedure, mechanical thrombectomy, there's a practice that they get a CT scan done after 12 hours as well, if they want to start it on early. But the usual practice is get a CT scan after 24 hours.
Thank you, ma'am. Are there any other questions? What is your practice in traumatic venous thrombosis and strokes associated with TBI?
All right. So again, I mentioned about this as well. So if there is any evidence of some hemorrhage, any kind of hemorrhage associated with TBI, we usually wait for 48 hours, get a CT done. If the CT imaging is stable, there is there is no hemorrhagic conversion, further expansion of hematoma or an increase in mass effect or midline shift, we usually go ahead and start on with pharmacological prophylaxis. Although I want to emphasize again that this is always individualized. Risk benefit has to be weighed for that particular patient, taking into consideration his factors, his age, or whatever risk factors are there. So risk assessment is always the first thing, and clinical condition comes much later.
Ma'am, I have a few questions that I've jotted down. Nowadays, for a traumatic brain injury, for severe TBI, tranexamic acid has become a standard So, is there any evidence that giving this tranexamic acid increases the risk of thromboembolism later
Yes,
on?
there is. And I came across a few studies which said that tranexamic acid is actually responsible for increasing the risk of venous thromboembolism in many of our patients in the neuro ICU. So yes, there is a clear-cut association between the use of tranexamic acid and thromboembolism. We have to be careful about that. Yes.
So all the Western studies have shown no benefit no benefit for tranexamic acid in intracranial hemorrhage. Currently, ICMR is conducting a study. It's an RCT that's ongoing. We are also recruiting. So that's kind of it becomes relevant when we use tranexamic acid in all these conditions. That's why I asked that. Second one, anything that you found on the difference between IPC and SCD?
A difference between SCD and IPC? No.
No, yeah, because in the general intensive care, the thought process is SCD is better than intermittent pneumatic.
Actually, if we see the mechanism, yes,
Mechanism wise, yeah.
SCD has to be better than IPC. Yeah, sequential compression. So from distal to proximal venous return. So I think theoretically it becomes better than IPC, although I never came across any studies that were comparing these two things. Maybe they are there, I missed them, but IPC versus SCDs I did not find.
And your point on intraoperative VTE, I mean, that's something that is new to me. Majority of the surgeons prefer to use TED stockings on the day of surgery. When the patient goes to theater, they put them on TEDs, and that gets followed even post-operatively. There was no mention of stockings in your talk. Is it
Talking
not
these
useful?
days, we are not preferring. I don't know. In your center, they still use stockings.
No,
Yes.
it just some of the
Okay.
centers use, and
So
some of
I have been practicing the use of IPCs intraoperatively and then carry them to the post-op as well. I don't know if it is a practice, but as you asked me, comparison between IPC and SCD, there is a lot of comparison between GCS and IPC. So they clearly say that no,
This is not.
avoid using compression stockings.
And what about combining mechanical and pharmacological prophylaxis, ma'am?
For yes, you have to combine.
Is that
You're
no,
asking
give both IPC and enoxaparin? Is that beneficial, more effective than either of
actually,
the
that
other?
is the protocol. So we
Okay,
have
so it's
begun with
combined.
IPCs and then we introduce chemical prophylaxis gradually and we continue with both.
Continue with both.
Yeah.
Because in general critical care, the evidence does not favor using both.
So
There's no
actually
benefit in
using
using.
simultaneous use of IPC as well as chemical prophylaxis decreases the rate of thromboembolism much more than using either alone.
Either alone.
Yeah.
Thank you.
You know, one thing that I want to emphasize is in our general practice, we just don't care about screening for DVT in our patients in the neuro ICU. And that is actually very sad. We don't take DVT that seriously. I was repeatedly saying that the risk is real, the risk is real. This was my statement repeatedly. So actually the risk is real. We should screen for DVT. There is a very high incidence of DVT and introduction of prophylaxis in the form of pharmacological prophylaxis is very, very important early on. People still don't go ahead starting on with clexanes even after 7 days after, the procedures have been done and CTs are stable because they don't think about it. They don't think that it is a serious enough problem in neuro ICUs. While again, I would stress the problem is real and it happens and it increases morbidity a lot.
We should also improve our DVT compliance rate in our ICU. Are there any other questions? I'll just check the chat. Nothing else in the chat box. There are no other questions. Dr. Prashant, are you still here?
Hi, Deva. Shalini here.
Hi, Shalini is here. Hi, ma'am.
Can I just thank Vasudha for her immense work she has done? Incredible amount of evidence she's brought up.
Yeah.
I just wanted to say one thing what she said, difficult for making the surgeons understand the need. I had looked up the literature a few years back. And the more the senior the surgeon becomes, the later he gives consent to start. I hope with all this evidence, we are able to convince them sooner than later. Thanks, Vasudha.
But the thing is,
Incredible
we
work.
have to convince ourselves first before convincing our surgeons.
That's true.
Most of
Yeah.
us are not to convince about starting a DVT prophylaxis early on. Actually, that's a problem.
Thank you so much.
Thank you so much.
Thank you very much. Dr. Shalini, shall we close the session?
Yeah, please.
Thank you very much, ma'am. Thank you. Thanks, everyone. Bye-bye.